Good morning. Welcome to Bradford Health Services' third education event for the year 2025. I am Zach Ludwig, Vice President of Clinical Services and Accreditation for Bradford. Bradford Health Services will be providing continuing education to you today for attending this event, which will be from 9 a.m. to 12 p.m. Central Time. Had a couple of questions already coming in about the timing of today's presentation, so I wanted to address that right off the bat. Want to thank you for joining us today. Bradford hosts these webinars on a quarterly schedule. We are planning to offer one additional session by the end of 25, likely in December. So please make sure you check out our website, specifically our events page, for upcoming announcements. Before I introduce today's session, I do want to share some important information about the session and how you get that continuing education credit. You are viewing this in the webinar format, which means that you can see me and the presenters, but your video and your audio are off. You must use either the chat, which I see a lot of you doing right now, which is fantastic, or the Q&A box on your screen, usually located at the bottom of your screen, in order to ask questions about anything discussed during the session, or to communicate with your moderator, myself, Sherry, or the presenter themselves. At the end of the presentation, we're going to have time for some discussion where any questions we get during the presentation that are not already addressed with the content or by the speaker, we'll have time to circle back to those as long as we have enough time allotted at the end. Please note that you will receive a post-session email, a very important email. It's going to have links to the materials you're going to see today. So you're going to get a copy of the PowerPoint slides. You're going to get a link to the video recording of this presentation. And really important is you're going to get a link to an evaluation, a survey. You must take that survey in order to get the continuing education credit. Today's session is eligible for 3 hours of continuing education credit. Bradford is providing that credit at no charge to you. Your attendance for attending this session is being recorded because of your login. So you don't need to put your name in the chat, though certainly feel free to. Like to see all the different folks coming from so many different places within Alabama and many of our surrounding states. If you want to give yourself a notice of that, please feel free to use the chat for that. I see a lot of familiar names and many newcomers among us. Welcome. So we are recording that attendance. After the conclusion of the session, and when you complete your survey, mention that a couple more times. When you finish your survey, you're going to get another email in about 2 weeks that's going to have that certificate in it. If you're not seeing that certificate coming through, make sure you check your spam folders. If you're still not getting it and you know that you did that eval link, you can drop us an email, but please wait at least 2 weeks before you start emailing us that you're missing your certificate. It does take us a little bit of time to process it. We do appreciate your patience on that, but we will make sure you get it. You have to do the survey within 30 days from today. I really recommend you knock it out at the end of the presentation. You're going to get it in that email that I've already mentioned. We're also going to be posting it in the chat box and in the Q&A box before we close today towards the end of the session, but not till the end. Go ahead and knock it out, get it done. Last quarter, we had pretty much everybody got them in really quick, and we were able to process those certificates really fast. If we don't get your eval, your survey within 30 days, we do close it. And at that point, I cannot give you continuing education credit. So if you email me next year and you say that you attended this session, I'm not going to be able to give you the credit. Sorry about that. If you'd like to go ahead and do it, please do it. If we experience any technical difficulties, so if we all lose internet and power, I'm here in the central Alabama area. It's a beautiful day outside. I'm hoping we don't run into any technical issues. But if we would happen to get popped out of this meeting, please try to join back really fast. If we cannot get this thing restarted again, we will send out an email to you at the email that you use for registration with instructions about how to rejoin or arrangements for a replacement session to be scheduled in the future. Or if we are able to get pretty much to the end, might be able to give you full or even partial credit for what you've already attended. Okay. I think that covers all the housekeeping and general questions we usually do get. So I'm excited to move into the further introduction of this session titled Levels of Care in Behavioral Health Clinical Challenges Impacting Outcomes. Our presenter today is Monica Mendoza. She's the Senior Director of Clinical Services for Bradford Health Services. Monica is a licensed professional counselor, approved counselor supervisor, licensed chemical dependency counselor, and national certified counselor. Monica is going to share more information about her experience and background with you as she gets the session going. It's my pleasure to turn it over to Monica this morning. Thank you.
Hi, good morning, everyone. Thank you to Zach for that introduction and for providing that important CU information for us. So yes, my name is Monica Mendoza, and it looks like we'll be spending the next few hours together. I'm grateful that so many of you could come on and join us today, and I'm equally grateful that our company has created this platform to be able to offer these CEU events to you. And I'm hoping that you can also take away some good information from this that you could take back to your place of work, where I'm sure you're doing very good work working with other people, and that you'll find value in what we're going to talk about today. And so this is the part where I'm supposed to tell you a little bit about myself that qualifies me to be sharing all of this information with you. I am, as Zach said, I am a master's level therapist, and I'm licensed in the state of Texas. Going back a little bit to the beginning of my story, I got my bachelor's degree in Honolulu, Hawaii, and I landed there because of the military, and we're a military family. So I graduate with a counseling psychology degree. And my first job right out of college was smack dab in Honolulu, Hawaii, Waikiki, in a domestic violence shelter. Um, wow, right? That's an intense job. I mean, bachelor's level, my first grown-up job. This is my first big girl job, right? And I quickly learned in this job that, well, I guess what I didn't expect was that this job would become so fundamental in who in my makeup and who I would later become as a clinician, right? There were some lessons that I learned in this job that helped to mold who I would eventually become. And so in this role as an advocate for domestic violence, you know, I'd go with them to court and help them file restraining orders. I would go to court with them again with their abuser in the house to request extensions, to request um, preliminary custody orders to be put in place. I would go to their homes with them with police escorts to retrieve belongings. I would provide support groups. And I feel like a lot of the elements that I focused on was really trying to encourage women not to go back to the abusive situation, because as we know, I mean, those situations can be extremely lethal, right? And so my office was situated right in the shelter, right off of the kitchen. And so as I'm starting my work for the day, I could hear the women in the kitchen making breakfast for their babies and getting their kids ready for school. Right. And so it was a very intimate setting. So the part that was very pivotal for me in a lesson that I learned in this position was during a treatment team. So all the players from this agency, from this safe haven that we had, they're all in treatment team. And they're talking about the new admissions, they're talking about the initial assessments, and it's very nonchalant. It's like, yeah, so she said that he kicked her like this, and he punched her like that, and he called her this, and he called her that. And I'm sitting there, like I said, fresh out of my first degree, right? And it it really took me aback because it just seemed so desensitized, right? And my ears were just burning because at that point in my career, my ears are very sensitized. I'm very sensitized, right? So my walk away from that was I did a lot of reflection. Felt like my walk away was ah I am gonna strive to always listen to stories like it's the first time I've ever heard a story. And so that became the first personal contract that I made with myself. And then so then I move on, I come back to the mainland. And from there, my mantra developed, right? From that personal contract, which eventually became, and I still operate off of it today. And in the way that I function in the clinical world, it's I let me please always be emotional about my work without being too emotional about my work. Right. And so I came back, I started my master's program and I continued to work in these fields doing case management. And again, I didn't realize that all of these social service jobs that I was a part of were preparing me. They were like my prep work for what I would soon come what I would do next, right? Is working with people with disabilities, either physical disabilities, medical disabilities, um, people trying to help people get off of TANF, trying to get people off of food stamps, working with offenders that were reintegrating back into the community, trying to help them become independent and trying to reduce recidivism. Case managing people through vocational programs and college degrees, people that had at-risk situations, and displaced homemakers, displaced workers, at-risk youth. And then there was another one that was very pivotal is I worked with families who had children that were medically fragile. They had medical complexities. And the service that I provided was to try to help keep them in the home. And otherwise, their conditions were so severe that they could end up in a nursing home. So we provided nursing home-like services in the home, right? And so from there, I graduate and and my first job, as soon as I got my LPC intern license back then is what we called the intern, LPC intern. Now in Texas, we call it LPC associate. Right as soon as I got that, my first job I took was a PRN position in an acute psych hospital that was in my community. And still doing my case management on the side. And then I was convinced to come in as a full-time therapist. Um, so here I am, full-time therapist now, right, in this acute inpatient psychiatric hospital setting. I don't know how many of you have worked in the acute setting, but I don't know if it gets any harder than that setting in the industry that I'm working in, that a lot of us work in. It is hard work, right? So then coming in as a program therapist, I'm all the things in one, right? I'm the group therapist, I'm the individual therapist, I'm the family therapist, I'm the assessor, I'm the discharge planner, I'm the case manager. I'm the person that prepares the transition, makes sure they get where they need to get. I'm all the things in one, right? And just a really hard job. Um, then I moved on to become a program manager where I started learning how to create clinical programs from scratch, right? And then became a clinical consultant in multi-sites and director of clinical services, and then moved on up to corporate clinical leadership and had the opportunity to jump in on a project to start a new behavioral health service line for a major medical corporation. And then here I am with Bradford now, senior director of clinical services. And all things clinical, right, are areas that I focus on, but there's a little niche that I have with the company where I am the primary person to oversee and to support and to help build out systems for patient retention, right? And so, as you know, Bradford, our focal point is addiction, right? And so patient retention in all settings is very important and equally important here in this city. So that's the role that I play. And so all of these experiences, right, they really leaned into molding I I hope I am as a clinician, and who I hope to continue to grow to be as a clinician. Um, and these influences that I've had along the way too, professional and personal, um, in that setting in that domestic violence shelter, that core, one of those core qualities that I learned there was how to provide care compassionately, right? And how to sustain that compassionate care. Um, and from a professional standpoint, influences, that I feel inclined to just mention, and Rob Marsh, he's the CEO of our company, and I'm not just mentioning him because he's the CEO of our company, but we go way back. But he was that influence that taught me how to wear a few hats, right? How to wear my clinical hat, how to wear my business hat, and my leadership hat, right? And then the late and great Harvey Martin, who taught me to always strive for platinum standard. And he expected that from himself. He expected that from me, and he expected that from everybody that worked with the patients, and the late John Salkeld, lost both of them this year. And his lesson to me, he was my first clinical director when I entered the field. And his lesson was centered around being just determination, despite obstacles, despite barriers, and to always look past that to help the patient to the greatest degree. And on the personal side, I think about my grandma, who she never worked outside of the home. She worked in the home. She was always cooking for people, always taking care of kids, always taking care of everybody. But when I think about that seed of compassion that just really grew in me and that I attached to in that domestic violence shelter, I see my grandma because she was my first lesson in compassion. And so going into our talk today, I feel like a lot of those, all of these elements that I just talked about, they all they're all elements that make up the house that built me, right? And I feel like in the presentation today, a lot of those elements and that flavor and that culture and that you'll feel it woven in to the topics that we'll talk about. And here we have our overview. There's four main areas that we'll look at, and we'll look at the introduction to the continuum of care, and we'll do it. Not we'll look at the basic part of it, but as we progress, we'll bring in a little bit more content and context to it. And our second point will be just the interagency challenges that we tend to be confronted with working this field, and some of the common missteps that have that we sometimes see and sometimes we don't see them. We'll also look at the impact to the patient and to the client, and then we'll look at a few things that we can do to try to create some synergy and create some seamless transitions between all of these levels of care. And so we'll start in our first section with the introduction to the continuum of care. And on this, and I do want to just give a heads up, I'm looking at my time here, but we will take a couple of breaks, okay? And we'll, a little bit after 10 o'clock, we'll take a 10-minute break, and then we'll take another one a little bit after 11 o'clock, okay? But here we have the 5 primary levels of care in behavioral health. And at the very top of the tier, we have our acute psych hospitalization, and in short, sometimes you might hear it referenced as IP psych, right? And so when I hear acute psychiatric hospitalization, I think crisis, full-blown presentation of symptoms at their highest crisis level. I think someone that needs 24/7 observational care. I think someone that needs evaluation and medication management to try to help stabilize these symptoms, right? And then I also think short stay. In an acute psychiatric hospital stay, it's a very short stay. I mean, we're lucky to have them for 10 to 12 days, right? Usually it runs at 7 to 12 days, very short stay, very short period of time to get a lot done. And then in the residential treatment setting, that's another level of care, and sometimes called referenced as res. In this one, when I hear this one, I typically think of addiction treatment, right? That's primarily where we have the residential treatment component. And in this level of care, we may get them for 20 to 30 days. Sometimes we can get a little bit more if it's a specialized population, maybe an adolescent population. We may be able to get a little bit more time with them. What I haven't encountered a whole lot of with residential treatment is in the acute setting, we would often get people that wanted to go on to residential treatment to work on issues that were more from the mental health side, non-addiction, their depression, PTSD, severe anxiety, and the residential treatment. Most insurances don't seem to cover that. Usually if you found something like that, it was a PHP with boarding, so this is one of those where if anybody out there has any resources where, or you find otherwise, please share that, because that's been an area where I've encountered a lot of roadblocks. And then our third level of care that we have listed is partial hospitalization program, often referenced as PHP. And it's exactly that, right? It's that person that is in that subacute state that's severe enough to need to be in a higher level of care, to be seen with regularity. In a PHP, we have 20 hours a week, and a lot of programs will run those 20 hours from like 9 to 2-ish, 9 to 3-ish, Monday through Friday. However, we're starting to get we're really starting, we see it in a lot of places, just trying to increase access to care for people that work or people that go to school, people that don't have coverage for their kids during the day, but they can go at night. So we see some PHP evening programs. We see some weekend programs as well now. And in this one, it depends which way you're coming, right? So if you're coming down from the acute side, if you're stepping down into PHP, a lot of times it's because somebody needs, they have resolved that acute crisis level. Right? I say it like that because it's kind of a slippery slope. We'll talk more about that as we keep going through. So they can be coming down from their stepping down in level of care. And it's to continue to stabilize those crisis symptoms, and they've come down enough to be able to get to that level. And they're safe enough. They're severe enough to need that 5 days a week daily clinical contact and intense therapy, group therapy. However, they're not severe enough to be in the acute, and it's okay for them to go home at the end of the day, right? And then we have the intensive outpatient program. And if you notice, as we go down, the step down, it's less restrictive and less intensive by way of symptoms, right? And so in our intensive outpatient program, which is dubbed IOP, that one is about 9 hours a week typically, and may run about three days a week. However, different programs will run it in different ways. Sometimes they'll embed them in with the full PHP. And then we have our traditional outpatient treatment, which is outpatient therapy. So how do I use the levels of care in my role? It's like, do they start at the top the same way for everyone? Do they start at the acute level, work downward? Do they start at the bottom and work upward? Do they start at the middle and work up or down? I mean, that movement is fluid, right? You can, yes, it's yes to all of them. Yes and no. I guess it doesn't have to start in one place. It just depends what your clients need. If you go if we go let's say the traditional route where you're at the highest level and work your way down, it's going to be the inpatient and sometimes the residential if you've got that addiction piece and they were in inpatient for detox or they came in for a psychiatric stabilization, but it was identified that they also have some addiction issues, not necessarily needing to detox. They might be routed to residential treatment. So inpatient psych to PHP to IOP and then outpatient therapy. So that's the traditional, I guess, if you say from top to bottom, but it doesn't necessarily have to work that way. It could go any which way, right? You could be an outpatient and swing over to residential treatment. You could be at the inpatient level and swing all the way down to outpatient therapy or just IOP. And so what's the caveat to all of that? It's depends on your client, depends on your patient. What are the symptoms that they're presenting with? Because every single one of these levels of care has a specific criteria, right? And so depending on what your client or your patient is presenting with, then they would then that's what they would be recommended for. Okay. So who can benefit from the information that we're going to review today? Just about anybody that works within your system, right, in behavioral health. The obvious ones are your inpatient therapist and your outpatient therapist and your psychologists and your case managers and so forth, your behavioral health techs. But on this list, and your nurses, right, and all your directors, but you also have your admission staff and utilization reviewers, risk managers, your compliance department, your PI department, and your CEOs, right? Everyone in your system for behavioral health has some kind of responsibility to make sure that the clients and the patients are getting what they need while they're under our care. So the independent versus the interdependence factor. Quote, the yin and the yang, right? It's the ancient Chinese concept of two opposite, interconnected, and interdependent forces that shape the natural world and that shaped human lives. When I think of the levels of care, my brain automatically goes, it centers on the interdependency between all of the levels of care. Sure, the levels of care are very powerful and effective as standalones. But remember that they're also driven by specific set of symptoms and specific symptom intensity. So if you're working with people who have chronic mental health issues, right, lifelong depression, bipolar disorders, there's an inevitability that at some point there's going to be a large number of people who will need a different level of care from the one that you're providing, whether it's a step up and then a step down. If no one's going to stay at the highest level all the time, right? So when I say that, I'm thinking about the lower levels, the outpatient therapy. There may be a time where your patient with bipolar disorder, your client with bipolar disorder, or with major depressive disorder, with PTSD, doing some intensive work, might need to step up to a higher level while they stabilize and then they can come back down. So that, and it's that moment when your person has to go to another level of care that you are confronted with how interdependent these systems really are toward the stabilization of the patients, right? And in us being able to do our job to the fullest effect, and how much we need the other levels of care to help us to accomplish that sometimes. Okay, so we close out that first section where we just did a basic look at the levels of care. And so we're going to move into the interagency challenges and some of the common missteps. So in this section here, we've got acute inpatient psych. And what I'd like to do is I'd like to look at acute inpatient psych as the foundation of all of the levels of care because of where it sits, right? It's the highest level of care with the most severe of the symptoms, sits at that top tier. So we'll look at that as the foundational level of care. Some of the common conditions that we find in the inpatient psych setting, depression, bipolar, psychosis, people that needed to come in to medically detox. And so we think, okay, so we see those diagnosis and all the other levels of care too. So how is it different here? Well, it's different because it's not just the depression. It's the depression when it spikes up and the symptoms have spiked up. And often the person is experiencing some type of suicidal ideations in association with that symptom elevation in their depression, right? But it's not enough because someone's not going to be able to come into acute setting because their depression is elevated. And honestly, someone's not even going to be able to come into the inpatient psych setting just with suicidal ideations at a base level. It depends where the suicidal ideations are, right? If it's passive ideations with a general wish to not live anymore, that typically would not be the acute setting wouldn't typically be the right setting for someone like that. Typically it would be PHP. It for the acute setting, and when we're thinking about suicidality, and we know that there's different levels with suicidality, right? There's the general wish to die, and then once you start getting into identifying methods, detailed plans, intentionality in following through, the desire to follow through, exhibiting suicidal behaviors. It could be gesturing. It could be holding a gun in your hand. It could be holding that rope in your hand. It could be standing on the edge of the bridge, right? All those are gestures and considered suicidal behaviors. But it's the planning and the detailed plan, the intention, and suicidal ideations that typically will dictate the highest level of care, the acute setting, right? And with bipolar, again, it's not just that somebody has bipolar disorder, right? And just to clarify, the depression doesn't always have to come from major depressive disorder. It could be in association with bipolar, right? It could also be situational. So with bipolar, it's not just the bipolar that would dictate this level of care. It would be the presence of a full-blown manic episode, right? Creating that mood instability. And what we see with that would be the risky behaviors, heavy impulsivity, just behaviors and presentation that are creating a risk to self and a risk to others. And those are key words when we think about acute, right? Is risk to self, risk to others. And then in psychosis, even with psychosis, it's not just enough to be presenting with features of psychosis for the acute setting. If there is, it's like, because the psychosis can be coming from a few places, right? It could be coming from a diagnosis of schizophrenia. It could be coming from a diagnosis of schizoaffective disorder. It could be a single episode. And so someone with chronic psychosis wouldn't typically go into an acute setting. When they would go into an acute setting would be when it is elevated above their baseline and it is creating some risk factors to their safety or safety of others. And what we'll see hallucinations, we may see delusions, paranoia. With command in nature is pretty common in this setting. And once you get to that command hallucinations, now we're talking about typically they're telling that those command hallucinations have some narrative around harming self or harming other people. So this setting here, the acute setting, anytime that I have a chance to mentor someone or to work with an LPC associate, it's one of the things that I say. It's like, at some point in your internship, you've got to get into acute psych. It's like the DSM is, it's just like just busts wide open. It's just alive, right? It's in a different way. And when I think, one thing I didn't mention is I do private practice as well. And even though I'm working right now in this setting, and it's deliberate. I do it because I'd like to just stay connected with that ground level work, because I feel like it'll help me to be more effective in the work that I'm doing at the corporate level. But the experiences that I've had in the acute setting, I don't know if it would work in reverse for me, but I do know that the way it worked out, I feel like I am a better outpatient therapist because of the experiences that I had in the acute setting. And that's how it's worked for me. Let's see. Okay, so let's look at some common challenges that we encounter in the inpatient psych setting. High symptom acuity leads to frequent safety interventions. Flow of admissions and heavy discharges is a norm. Diverse populations within the same system and in close proximity. Limited time and treatment for adequate assessments, acute stabilization, discharge planning. Caseload heavy with extensive discharge planning needs, and the expectation of residential type treatment in a 7 to 12-day stay. So let's swing back up to the top. Let's start with high symptom acuity leads to frequent safety interventions. Because we said, right, that in the acute setting, there's that factor of risk to self, risk to others. And for those of you that are familiar with the acute setting, have worked in it, or even walked through it, it's hard not to notice how different the environment is. When I think about safety interventions, one of the things that we'll notice is that all unit, it's, we have, of course, it's not the same as residential. In an acute setting, it is a lockdown. You can't just walk out. You have to have a doctor's order to leave, and the doctor has to assess if the physician deems you safe enough to be able to leave. And if you're wanting to leave and the physician doesn't deem you safe to leave, that's when court commitment applications will typically come into play. When we think about walking through a unit, and the term psych safe comes to mind. A lot of you probably heard that phrase, right? Psych safe. And in this environment, I mean, everything, it's just a pristine environment, and as far as mitigating risk, it should be, right? I'm thinking like this pen wouldn't be okay in that setting, because this pen can be used to harm yourself or harm someone else, right? Or like maybe these glasses, right? I mean, we want our patients to be able to use glasses, but we also have to be really careful, because there's so many parts of these glasses. If you really think about it, if you wanted to hurt yourself or wanted to hurt someone, there's a lot of parts of this that they could use to do that. Or like these keys, right? If I wanted to harm myself, I could cause lacerations with these keys very easily. I'm looking around this room, looking around the room that I'm in, and I see an ottoman over there, and it has these wooden legs, and the wooden legs can be unscrewed, and there's hardware there, so that would not fly, right? I'm looking at the outlets, the electrical plugs, and they have the little screws, right? Little Phillips screws, or the flat head screws, and that wouldn't be okay either, because people can take those screws off and use those to hurt themselves. So they have to use tamper resistant screws. And I mean, it's endless, everything. The way the door swings in and out, right? It's if the door needs to swing out, because we don't want patients to be able to barricade themselves inside the bedrooms. In the bathrooms, the doorknobs are huge. right? Hinges, all of these, uh, hardware pieces that can be used to strangulate yourself, right? The bathrooms, your shower heads, even the soap dish, right? Everything, the soap dispenser, all of these things are crafted for safety. So that in this environment, you can walk down the hallway in an acute setting and see a paper clip on the floor, and that's an urgent situation. It's like there's a paper clip right in the middle of the hallway in front of the patient's rooms. We need to be careful, right? Um, so let's go to the next one. Flow of admissions and heavy discharges as a norm. And I get it, because in the residential setting, we get that too. If you're like, there's some facilities, it's like, oh my goodness, they have almost 200 beds and hundreds of discharges a month, hundreds of admissions a month, and that is such a rapid pace. But there's this different quality about the acute setting, because in the residential setting, you get to keep them a little bit longer. Not always, I know, because there's early treatment exits, right? But and I know that when you're working the residential treatment setting, it doesn't feel like a long time. Um, but it's a good amount of time when you compare it with 7 to 10 to 12 days, right? And so when you have, and as a therapist, you're getting, it's not unusual to have 2 admissions every single day, and have 2 discharges every single day as one therapist. And it's a constant. And that's probably on the low end, for some facilities. So that rapid flow is a huge challenge. Diverse populations within the same system. Um, you know, I want to go back up for just a second. Just want to make this point of how, I mentioned that paperclip, right? It reminded me of this situation, um, where even the things you wouldn't think of, somebody taking the little teeth off of the plastic forks from the dining room, um, and keeping them and making significant lacerations that required, extensive sutures to repair. So it's like even that tiniest thing, right? And so when somebody truly wants to hurt themselves, people get really creative and they dig deep in their environment to find something. So going back to that diverse populations within the same system and in close proximity, in the acute setting, the inpatient setting, it's not unusual for there to be varying populations in one unit. 40 bed 40 bed wing, and you've got somebody medically detoxing. You have somebody in a psychotic episode. You have somebody in a manic episode. You have somebody that came in after a suicide attempt. And you can easily have all of these conditions in different populations in the same wing, right? And not every organization is going to be able to have the resources to separate them all and to have their own little specialty units. That's ideal. And there are many organizations that do have that, but there are also many who just don't have the resources to be able to do that. And we have to get really creative on how we program so that everybody is benefiting, and we find creative ways to try to organize organize this inherent chaos. Right now, when you have somebody that is functioning at a lower level at that time because of their acute state, let's say like someone with features of psychosis at that time, and they're not typically going to care too much about the others, except that they're inadvertently affected. If there's a lot of chaos, it may increase their paranoia, their delusions. But as far as saying, well, he's bothering me and I can't concentrate on my therapy because he's just too loud. You're typically not going to see that. They're not going to care about that piece as much, but other patients that are functioning at a higher level, that are there stabilized suicidality, that are there detoxing, that are coming off a manic episode, they care very much, right? They care very much about that. And so we have to become very creative at how to navigate all of this, um, and still allow everybody to benefit from it. And the next one, the limited time and treatment for adequate assessments, acute stabilization, discharge planning. We get 72 hours to do all our assessments, and that's in most settings, right? But there's a different feel in this setting, because once day 3 comes, we might only have them for 4 more days. Right. So, and usually you have your admission assessment, you have your pre-screening, your admission assessment, you have your nursing assessment, 8 hours, you have your H&P 24 hours, psych eval 24 hours, psychosocial assessment, 72 hours. And 72 hours is, although regulatory, it's pretty late when you're only going to have them, a few more days. That's something that I advocate with teams that I work with, is try to catch it earlier. If you can catch it at that 48-hour mark, it can make a big difference. And so when I say adequate assessments, sometimes we're just going so fast that it's so easy to miss critical things and barriers, right? Things that we might plug under case management, things that are important from a medical standpoint, for medication management decisions. And so for the hope is that we're reading back and we're looking at the assessments that other people are providing, right? That other people are completing. And three, I guess, from 3 viewpoints. One, every discipline has their specialty and provides a different viewpoint, right? But then there's also that building block. And sometimes some clients they kind of have to warm up, and then they'll share more as they go in that process. And then others, they just connect with some staff more than they connect with others for whatever reason. And so some can get more out of another. And so if we're not reading each other's assessments, it makes it really hard to get a full picture, and part of regulatory standards are that all of the conditions and the symptoms that we find across assessments, that those make it onto the treatment plan. But we're challenged to accomplish that a lot of times. And then in the discharge planning piece too, sometimes there are things at the very front end that could have helped us, right? And what we're needing to work through over here. So that readback system is really important. And if we don't do that, we'll often find discrepancies in information between different assessments. Caseload heavy with extensive discharge planning needs. In the acute setting, it's not unusual to have caseloads of 12, 14, right? And as we talked about before, when we were first doing the introductions, in many settings, you are all things. Some organizations may have a separate case manager, say a discharge planner, but I've come across many that the entire beginning to end is managed by the therapist. There's some pros and cons actually with that. So I've tried it both ways. Both are challenging, but if it's a manageable caseload, I tend to favor handling everything, one person handling everything, because then you have less holes, less gaps. When you have different people handling things, it's hard to establish ownership, and you miss things in between, unless you have to have solid systems, solid processes to make sure that you're filling those gaps, right? And that the patient doesn't end up short end of the stick with that. And then the last one, expectation of residential type treatment in a 7 to 12 day stay. Um, and it's true, some of the patients that come in, that especially those that are functioning at a higher level, they have that expectation of one-on-one therapy with their therapist in the acute setting. They don't want to do just groups, right? And so we have to find creative ways to give them attention, that individualized attention as well, right? In a realistic way, so which can be a very challenging thing. Going back to the diverse populations within the same system, I speaking of challenges, I can recall this one time that I was working as a director, and I was leading a group, and I was in this group room, large group room, was also a community area, and I had maybe about 20 people in there. And because we have all walks of symptoms in there, um, it sometimes would lead to this, but I'm in that group room, about 20 people, and I'm the only one in there. I didn't have a tech in there with me or a co-facilitator or anything of that nature, but we did have the behavioral health techs walking by pretty frequently because they're doing their safety rounds, right? Every 15 minutes, they're doing their safety rounds. And so I'm in there, things were okay. Then all of a sudden there was this one gentleman that he was experiencing a manic episode. But during his time in this group, he was sitting in the chair. He was a little restless. He'd get up, he'd walk around, he'd pace, but he wasn't directly affecting anybody. Indirectly with his restlessness, maybe a little bit, but not directly affecting patients, right? Then all of a sudden he gets off from his chair. He goes and he jumps on, yes, a treadmill that was in that community area, and he turns it on full blast as the highest level he could put it. And he's just going as fast as he can go. And he did that for about 5 minutes nonstop. Just wait. And then he just stopped it, and he jumped off, and he went straight back into the group. He went straight to a gentleman that was sitting in the chair in the group, went over him and started screaming in his face, hovering over him, right in his face like this. And in that moment, it's like the lessons you learn in this environment, right? It's like, what am I going to do? What am I going to do? And then something kicked in. I had to do something because I'm thinking he is going to get up. The gentleman that's sitting down is going to respond to this. He's not well either, right? So he's going to say something, he's going to do something, and this is not going to be a good situation. I get up and I go over to them, and I immediately turn over. My thought was, I tell a patient, go get help. And I come back to these two, and I'm thinking, I can't really reason with the gentleman that's in the manic episode. He's not in a logical state in that moment. And all I had was the gentleman that was sitting down, the patient that was sitting down. And I just told him, look at me, focus on me. Don't look at him. Don't get up. He's not touching you. I'm not going to let him touch you. Just look at me. And I didn't know if it was going to work, right? But it's what I had in that moment. And then and this is another one of those where it's like, everybody in the setting needs to be prepared with training on, and this is a type of setting where we will sometimes see, we do see restraints, safe holds, right, for the protection of the patient or protection of other patients. And so in that situation, I'm thinking, if he puts his hands, I'm going to have to use a safe hold, and hopefully I can hold him. And if he turns and he hurts me, this whole room, who I have good rapport with, is going to jump in to try to help me. And I can't let that happen, right? So I'm just hoping that this strategy is effective, and it holds just enough time for somebody to get in here to help me. Lo and behold, it worked. Lucky that it worked. But I'm not in the acute setting anymore at this current time, but those instincts and those skills, they're still there, and I don't know where else I would have learned them. right? So valuable skills that I've been able to take with me, but it also depicts um, some of the things that we're talking about here. When we talk about safety interventions, boom, you got to think fast. Talk about diverse populations and the challenges that can surface from that. Okay. And we'll go through this slide and then we will get ready for a break, okay? So we go into the residential treatment, partial hospitalization program, and intensive outpatient. RTC, PHP, and IOP. And so I say with emphasis, the acute setting, it's critical for stabilizing severe symptoms. And if stabilization fails, the downstream systems struggle, right? So if stabilization fails at the acute setting, the downstream systems struggle. The RTCs, the PHPs, the IOPs. Um, in my current line of work, we'll hear how challenging it is to have somebody come into these levels of care that seem like they're still acute. And often they are, and they have to be stepped back up. But there's usually some fallout with some of that. And so that's an example of that downstream struggle, right? But in these settings, you'll still see some similar challenges as in the acute setting. It just might look a little bit differently because of the symptom intensity. So like, for example, the first one, managing diverse populations within the same setting. PHP sees that a lot, unless, again, they have specialized programs, right? But there are some PHPs they will have people coming down from acute setting that stabilize suicidality, stabilize their manic symptoms, just finished medically detoxing. And again, there we are with that same struggle, trying to find those creative ways to make sure that we're balancing our programming and individualizing enough so that our clients are benefiting. And then there's still, I mean, yes, they're deemed stable, but you only get so stable in 7 to 10 to 12 days. It's getting you out of that high level crisis, that crisis state where you may not immediately be wanting to harm yourself, but you're still in that stabilization phase, right? So when you're coming down to partial, it's still kind of rocky. I mean, you're kind of floating like this. You're not having the deep hills and valleys, but you're still waving and trying to find your footing. And so PHP teams struggle with trying to provide care while still monitoring and making sure that the stability is holding, making sure that they're not missing anything because remember, they get to go home at the end of the day, right? They're not in this psych safe, lockdown, 24/7 clinical setting. PHP, ILP, they get to go home unless, of course, um, you have boarding for your PHP or IOP, but even then, it's still, there's a lot of liberties still, right? So it can be a very scary level of care when they're just right underneath that crisis threshold, right? Addressing co-occurring conditions. This one tends to go heavily toward RTC, right? When someone's coming in for addiction treatment, sometimes it's difficult at times not to become centrally focused on the addiction piece, that it's easy to miss some of the co-occurring issues that someone may be struggling with, and they have such a huge impact on how someone assimilates, how someone commits, how they move through the stages of change, how they're able to integrate into the programming that's being offered, how they're absorbing all of the teachings. It has heavy bearing. Um, in in the RTC level in addiction setting, a common thing we might hear is he doesn't want to go to group. He's not ready to get sober. It's recurring themes, right? But I've spent some time in meetings, drilling down, doing root cause analysis on some of these discharges, trying to understand why certain patients exited treatment early, so that hospitals, facilities can get a better grasp of what systemic issues are contributing potentially, right? Or what misses, maybe what was missed that could inform program enhancements, process enhancements. And that even when we're sitting there completing a root cause analysis, it's not unusual for the obvious co-occurring conditions, symptoms to pop out, such as, oh, is it that guy that was acting manic? Or is it that girl that's like having a panic attack every other day? And in the process of evaluating why someone left early, sometimes it gets missed. And we're stuck on the, she's just not ready to get sober. But the reality is that addiction often is a symptom of another mental health condition, right? Like PTSD, right? There's a lot of anxiety that's coming from different spots, and one of them is trauma. And we know that there is a lot of trauma in the addiction population. So when somebody doesn't want to go to group, and sure, it could be that they're just coasting, or they're not ready, or they're being lazy. Could be, sure. But it could also be hypervigilance. It could also be that being in a room with the loud voices, it could with being elbow to elbow. It could be too much for someone with anxiety, PTSD, or so forth, right? And so we sometimes miss that from the very front in the pre-admission, in the admission. And I recall one in particular, he wouldn't go to group, and he voiced it. He said, I don't like the groups. I'm not getting anything out of them. And when we did the RCA and we dug into that admission, you know what we found there? That when he was in school, he had learning disabilities and was in special classes. So it's like, okay, I get why he wasn't getting anything from it now, you know? So addressing co-occurring conditions and acting expeditiously as we can when we do identify it, right? It's not always that we don't see it. Sometimes we see it and our system can be slow. So it's something that we want to look at, right? How expeditiously we are routing that person in for evaluation and for medication changes if that's warranted. Tailoring interventions to individual needs can be a big challenge, and clients may appear stable, but they exhibit dysfunction in community settings. That's a big one too. Requiring, and then there's the last one, requires advanced assessment skills to identify unspoken barriers, such as anxiety and trauma, to integrate findings into treatment interventions. So it's the advanced assessment skills. What that's talking about is the things that the patient isn't telling you, more of the observable, the clinical inference, right? The observable things, and asking questions that are not just the obvious question, but then asking those follow-on questions and trying to get a deeper dive. Okay, guys, so on this one more slide, and then we'll I think, give me a second. Yes, one more slide, and then we'll move on to our break. Give and get perspective. So when we're talking about, and I kind of wish I had I guess I did in the first slide, but a give and a get perspective. It doesn't matter if you're stepping someone up, if you're stepping someone down. It's everyone has a responsibility in that process of stepping someone up and stepping someone down. It's a two-way street. We all have a responsibility in it, right? Whether it's to provide specific information or it's to request specific information. And then we go the phrasing of inherent versus inherited. There are some challenges in these environments that are just inherent to the business that we're in, right? Some of the chaos is just inherent. But then there are other things that are inherited, right? The missed collaborations, the no aftercare summaries, those elements that we have control of are those inherited pieces. And so what we want to do is start finding where our control is and start and remember to move in that direction. Okay, so let's go ahead and let's pause now for a break. And it is right now, it is 10:06. So let's go to about 10:16. Let's take a 10-minute break and then we will reconvene, okay? Thank you. Okay, so we are gonna start back up. I hope you enjoyed that break. I needed the break too. And so this next section that we're coming into is when challenges turn into missed steps. Okay, and so looking at some systemic issues and fallouts. So here we have typical fallouts in acute settings, right? And we've touched on some of these. We're going to touch on them again, okay? Inadequate screening and assessment misses. In this area here, we talk some about that, right? When we're just moving so fast that it just becomes a document to fill out sometimes, as opposed to the tools that we need to inform the care that we're going to provide. And no one's immune to that. I think every setting can experience that because of just how fast life is moving, day to day in these environments. And so what are we, again, let's go over that. What are we hoping to get, right? When we're assessing, when we're screening, we're hoping to get disciplines to provide their discipline specific contribution there. From that lens, right? We are hoping to capture all of the symptomatology. We're hoping to capture past treatment history. We're hoping to get to identifying what barriers we're going to be confronted with. We're hoping to identify what their baseline is, right? Gosh, without knowing what their baseline is, it makes it pretty hard to know when we've reached max benefit, when they're ready to transition. And so one of them that I don't know, I tended to really like that mission assessments because it was like my first quick view, right, of all the things. And the other part that stands out to me when I think about the admission assessment is oftentimes family will come with them for the admission, right? Especially in acute settings and in residential settings, especially in acute settings, they'll come with them to the acute settings for the admission. And so admission staff often will have that face-to-face time with family where they're able to get more information, right? About the patient that the patient may not be necessarily self-reporting, and that is valuable information. And so again, the treatment team, we talk about the treatment team. Sometimes we can tend to work in, we're going like interdisciplinary and interagency collaboration. I think about the IDT. In that fast and furious world again, sometimes we can tend to work in silos, right? Where it's an environment where everybody has their part, but it relies heavily on us being in tune with each other. If, for example, like when you have your treatment teams and you have that opportunity to talk about with all your disciplines, talk about all your cases, not just the people who are struggling, but the people who aren't presenting with extra issues in the milieu or problematic behaviors or so forth, but we're looking at everyone so that we get a good view of how people are moving through their treatment, right? The good cases and the challenging cases. And then there's so much reliance on the direct care staff, the physicians, they rely heavily on direct care staff to feed them information, to let them know what they're seeing in the milieu. Behavioral health techs, it's often said, right? They're the ones that spend the most time with the client, with the patients. But if nursing nursing is pretty good talking with the doctor. But if the techs aren't telling the therapist, if the therapists aren't telling the doc, if the doc isn't getting the real picture of what's happening, and the doc is looking in the chart, trying to find documentation of how patient X is doing, right? Patient X, well, There's nothing significant in here that says the patient is not doing well. Um, and the doctor is reliant upon chart information, verbal reports, and self-reported information from a client, from the patients. He may not always have the best information at his hands to make the best decisions on ongoing medication needs, right? So that interdisciplinary is just so important. People talking to each other, in this world of technology. I remember in the good old days, um, I mean, we hung around the nurse's station all the time. They were knocking on our door all the time. Nursing was at our door. We're at their nurse's station. We're always talking. And now in this world of technology and messaging, and now we have just a bunch of email threads, and we have the chats and so forth. And I'll go into situations. It's one in particular that I can think of. It was this one gentleman came up to the nurse's station and says, I'm getting ready to discharge. Who's going to call my Uber? And the nurse said, I don't know anything about an Uber. But I don't know how you're getting home. I don't know what your transportation plan is. And it's like 6:30 p.m. So we call, right? We're calling the clinical team. And then the clinical team says, oh, we sent a chat or an email, right? And the nurse is like, but I don't read the chat all the time. I'm so busy, right? I'm like, but the office is just right behind the nurse's station. Why don't you just get up and just walk over there and just talk to your teammate and say, hey, I'm getting ready to leave. Um, he's gonna need an Uber and he's gonna leave at about 6:30. I just want to make sure that I give you that handoff. Just that good old fashioned way of communicating with our team, right? And making sure that we have that cohesion and that we're confirming that the messages are received. Those small things are big things quite often. Okay, so just interdisciplinary communication. And then we have our interagency collaboration that leads to fragmented care. Here we've got, if we're keeping acute as our top, our foundational, and people are sending patients up. We've got outpatient therapists sending patients up. We've got nursing homes sending patients up. We've got RTCs sending patients up. And a big miss is when we are not making that contact with that referent early, right? Couple of reasons, right? We want to make sure that we're keeping them in the loop on how their person is doing, because eventually their person should be going back to them. And also we want to get information, because if they have been treating this person in the outpatient setting or in another residential setting, we want to know what they know, because it may shortcut some of our assessment process. We may not have to invent too many wheels, right? If we're collaborating with referents and we can get some good information from them. And now let's go with the nursing home. Nursing homes get very upset when they don't get called, right? They want those regular updates. And if you try to get close to that discharge date and call to say, hey, we're sending your person back to you in 2 days, it's very, very likely that you're gonna get a I haven't received any updates. I need nurse's notes, right? And someone on my side will need to review the nurse's notes. We will need a PASSR, and the PASSR, and so that will require someone coming in and doing their own assessment. And then once we review all of the information, if we think that the notes are reflecting someone that's stable, then we'll call you to collaborate for the transition back to us. But then guess what? You're like on last cover day, right? you're on last cover day, and by your account and your team's account, this person is ready for discharge. They're not presenting with enough acute symptoms anymore to be able to get extended days. So now you're in that bind, right? And sometimes sometimes nursing homes are not planning to take the person back. And I know, there's some states that have some laws around that we can tap into. But sometimes they're not planning to take a patient back. And when we're not talking at the very beginning with the referrents, we don't know what to expect. And then we're getting to the tail end and they have nowhere to go. And I don't know about you guys, but finding a nursing home for a patient that has demonstrated some difficult behaviors that they needed to come into the acute setting to stabilize, not so easy. Sometimes when we have some connections, but not typically. It's not an easy feat, right? It could take weeks. It could take weeks. I've seen geriatric patients ready for discharge post acute already, no longer meeting medical necessity, a month out, still in, because they're struggling with finding someone to take them. So that collaboration is so important. And even, I mean, from an RTC standpoint, right? Any of these levels of care, it's gonna be an important step. Let's say you got your outpatient therapist and you're getting ready to discharge Monica. Monica, I'm sending Monica back to you. Can we get her an appointment so she could see you within 7 days of her getting out? And it's like, well, where's Monica gonna live? Well, she's going back with her husband. And oh, well, the last couple session I had with Monica and her husband, he said he was not going to take her back and he already changed the locks to the house. Oh, well, where is she going to go? I don't know. You got to help her find something, right? So our partners out there could very well have valuable information, and it goes both ways, right? Valuable information. Let's go to insufficient monitoring of program integrity. Again, I mean, we can have the most amazing program schedule, the amazing group build out, right? Program integrity is often an area that is challenged. Of course, nothing is everything, right? No, there's not, it's not an all factor here, but program integrity is definitely one of those areas that can be challenged by canceling groups, not starting groups on time, cutting them short, not having quality content in there, that it's a redundant content. And so why do I bring this one out? Because this one has a particular relationship to patient retention, right? When as soon as a patient feels that he or she is not benefiting, if they're already close to, if they're starting to trend towards stabilization, they're going to want to go because they're going to be bored. They're going to feel like they're not benefiting. They're going to say, I can do this at home, right? And so the program that we offer is such a big piece, even if they're coming in from medication management as the primary, right? The program is still such an important aspect of the stabilization process. And it's heavily embedded, as I mentioned, in patient retention and heavily attached to dissatisfaction, right? There's a reason why on satisfaction surveys, we have things like uh, um, satisfaction with therapy, satisfaction with medication, right? Because these tend to be hotspots, right? So this is one of the fallouts in acute setting. And then we go to discharge planning fails ongoing needs, reconnecting patients with community supports. This one, I wish that I could tell you, I don't see this a lot, but I do. In that assessment process, sometimes in that hustle and bustle, we don't get enough information on who their outpatient treatment team is. They may be a walk-in, they may be coming from the ER, right? They may not be coming directly from a referent. And if we're not asking, do you have a psychiatrist? Do you have a therapist? Do you have a primary care, especially for somebody that might have some medical conditions that has a treatment plan while inpatient with our facilities? Will need to be connected with a primary care or with a specialty. If we're not getting these, you know what's happening? They're they're being connected with completely new people, right? Unknowingly, right? And a lot of times it's because we have connections, right? And we need action. We need it to happen fast because we need something in 7 days and I need it by tomorrow to put it on this discharge form, right? So then we have our connections. And so this is a big fallout when we are not doing a deeper dive on who their treatment team is on the outpatient and we set them up with a whole new team. That's really frustrating for the people that are treating patients in the community. That is really frustrating not to get your people back. And it's very frustrating for the patient to have to start over with the team, right? So we'll touch a little bit more on that. Let's keep going. Residential setting misses. And we've touched on this a little bit already, right? The misconception that residential settings are not acute. And sometimes that leads to missed acute symptoms. Because we have that hyper focus on the addiction symptoms, right? And sometimes even if we are identifying them, the wait time or the delay in expediting intervention can be too late. In a residential setting with addiction, it's when you're doing root cause analysis on where you're losing, what are the clinical trends in early exits from treatment. A major hotspot is those first days, right? The first 4 days, the first 7 days, those first days are critical. And if someone is already uncomfortable, they're not feeling like they're getting what they think they should be getting, they're just going to disengage and go. Right? Struggle to assess barriers up front, which hinders sustained integration into the residential programs. And again, that we're talking about maybe certain conditions that someone might have, and it's hard not to land on the trauma one often, but it's such a prevalent one that it's just hard not to touch on it, right? And so delayed identification of these escalating symptoms, right? We just mentioned that. And then I want to go to the last one. Impact of staff to client interpersonal skills. We've touched some on the other ones. We haven't touched on this one. But it is a frequent occurrence. Again, in that hustle and that bustle, it's not unusual for us as providing staff to miss or to not note how our nonverbals or some of our verbals or our tone sometimes can come across, right? If a client comes on, see it many times, client comes up to the nurse's station and it can take a good while before that client or patient is even acknowledged. It's like no eye contact, no acknowledgement that they're standing there. And if they do, sometimes it might be, what do you need? And you're going to have to wait. You already got that. I can't do anything for you. I can't see you right now. It'll have to be tomorrow. And so sometimes in our own busyness, we don't necessarily intend to portray that, but our stress will portray that. And the clients are going to interpret what it means. For us, it'd be like, oh, that's definitely not how I meant it. I was just having an anxiety moment. I was so stressed because I needed to get these court papers over in 10 minutes. And if I missed it, I was going to be done for. So it's like, we don't know what people's stories are, right? But the perception for the client is going to be, I'm a bother. They don't care, right? And so what happens? It triggers the client, and the client bites back. The client will escalate in behavior to some degree. And the patient escalating in behavior, whether it be verbally, behaviorally, whatever it is, it bails us out. I use that phrase a lot, by the way. It's like, certain people in my life that can trigger me. And whenever I'm going to be around them, I like, okay, I'm going to write it down on my arm. Don't bail her out. Don't bail her out. Right. So when we in kind respond, it bails people out. Same thing. So when our clients and our patients act out after being triggered by our interactions with them, they're bailing us out. But they have sometimes they have credible reason for being annoyed. And they're not entirely stable, right? So their tolerance level, their threshold for stress and confrontation is going to be impaired, right? So that's such a big one. Just basic customer service skills, right? Whenever I think customer service skills and I think about like that prime location, I don't laugh at me. I think about Chick-fil-A, and I think a lot of us say that, right? They have it down, right? They have their standard phrases. They have that just that warmth and that welcoming presence. And who knows? They probably go in the back kitchen and cuss up a storm before they come back out. And sometimes we might have to do that, take a step back somewhere where we need to reset ourselves. But so this is a big miss sometimes. Okay. In the outpatient setting, acute settings at times miss the reconnect with the active outpatient providers, and that disrupts the continuity, right? We talked some about that. That there can be a hesitancy to refer to higher levels of care due to the fear of losing your patient. That's not good. Because if your patient needs a higher level of care, we want providers to have trust in the system. We want to have trust in each other's level of care, whatever piece of the puzzle that we hold, in our hand. We want to be able to trust our partners, and our partners trust us. Referring without a handoff or ongoing collaboration through stabilizing care. Again, if we're going to send somebody up, right, we may not necessarily send information along with them, and that can slow down the progress to stabilization, and then vice versa. Resuming care without a clear review of treatment outcomes to include medication changes, diagnosis changes, and ongoing recommendations. So in this one, if sometimes we get our patient back at whatever level of care, and if at times we may miss doing a good review of, well, what happened while they were in that other level of care. I need papers. I need to see, did any medications get changed? What did they find out? Were there diagnosis changes? Did they start some type of care that I should continue here that there would be a benefit for? Were there any psychosocial issues that came up that I should be informed about? And so wanting to know those details is really important, right? And so I'm going to put my outpatient therapist hat on. Sometimes I don't get the aftercare paperwork, right? True story. So what do I want to do? I'm going to call them and I'm going to ask them for it, right? I want to know. And in some situations, in certain levels of care, and depending on what role that you play, there are times where a patient might be expected to hand carry their aftercare form to their next provider, and they just don't. And then the receiving provider that gets them back just goes off of the old medication list, but there had been medication changes made. So it can just get very messy when we don't commit to reviewing those treatment outcomes when they've been in another level of care and they're returning back to us. Okay, so we're closing out that section now, okay? Let me check myself on time here. Okay, so in this section, we're looking at impact to the patient and to the client. So, it's kind of been progressive, right? What are these levels of care? What are some of the challenges we've been confronted with? What are some of the fallouts from that? Now so how is the patient impacted? How is the client impacted?
Well, you did it right.
I'm not going to say anything to that just yet. Okay. I plugged this in here just another reminder that we often will talk about very sensitive topics, and I just want to give disclaimers, especially when we have discussions around suicide or any type of violence that we may encounter in our field, in our profession. So I just want to give a sensitive warning. So meet Jane Doe. I want to introduce Jane Doe to you. Some of her background. She is married with children. No previous psychiatric history or experience with mental health system at any level of care. Never been to therapy, never been in a hospital, a PHP, none of the levels of care, none. Close family system at first appearance. In the presentation, she's presenting with an acute episode in response to an unexpected tragedy. So in this spot here with Jane, when we're talking about this unexpected tragedy that she experienced, it's a perfect segue, right, to for this, because we just came off of talking about those, and I feel like customer service is doesn't quite capture it. What I do feel captures it is when we got to when we were at the very beginning and we were talking about being desensitized versus being sensitized, right? So it all and monitoring our verbals, our nonverbals, our facial expressions, all our body language, how important all of that is. And so in this situation with Jane Doe, her unexpected tragedy was that her husband died by suicide, and she was the one that found him. On this night that she found him, and and it was in her home, in their home. So on this night that she found him, she became so destabilized, which I think any of us could understand that. And so there were a lot of concerns around from the family, and law enforcement. There were concerns about her stability and her ability to make it through the night on such a critical night, right? So she was taken not by choice. She actually, Jane will say she was coerced to go get an assessment. That's how she will say it. They said, you're just going to get assessed and then they're going to let you go. It'll be quick. It'll be fast. It'll be easy. Right. And so, and I get it. I think in that moment, number one thing is safety, right? We need to get Jane to safety. That's number one, right? So they take her to the acute psychiatric hospital for an assessment, and they assess her and they admit her. They put her on a 72-hour hold and they admit her. Okay, she's resistant. She doesn't want to be in there. I mean, it's the night that she just lost her husband. She wants to be home with her family, surrounded by her family and mourning with them. She doesn't want to be in this hospital with other patients and in an environment that sometimes feels very sterile, right? And so she didn't have a lot of choice in it in that moment. So as she gets into her stay, she's in her bedroom. And you, if you've been in any hospital setting, really, at night, it can be so quiet. You can hear everything. You can hear, what's the phrase? You can hear a pin drop, right? You can hear somebody sniffle. You can certainly hear somebody talking, right? So what she heard was what you heard in that slide. So the staff were talking at the nurse's station, and they were talking about her case in particular and talking about how traumatic it was, what she had found, and what a traumatic way her husband had died. And in response to that, one of the staff said, well, he did it right. And Jane heard that. So from there, she already didn't want to be there. But from there, immediate distrust. Any potential trust any potential trust obliterated. She wanted out. She was going to say whatever she needed to say to be able to leave. Okay. If she was suicidal, she wasn't going to say it. She was going to play the game so she could get out of there because she didn't trust anybody in that place. Okay. And that's the start of Jane's story, right? It's like, man, and you know what? That staff is probably amazing staff. They just had that one moment of a slip of not being aware of the environment, and a desensitized moment, you know? It doesn't mean they're bad staff, right? All of us are susceptible to such a mistake, right? So we have to be very vigilant, and it's unfortunate because it did lead to, at a time in her life when she needed the system the most, she wasn't willing to accept it, right? Any level of it. She didn't even want therapy, no therapy. So we come here and we look at how missteps turn into negative impacts for patients and clients. And from this list, we can see some of them that impacted Jane, right? Patient retention, trust in the mental health system, trauma recognition applies here. She had just experienced a trauma. Being in the hospital away from her family during the night probably felt very traumatic. Hearing what she heard was probably re-traumatizing. Right? We have medication management, some of the missteps that we have, and we'll talk a little bit more about how that impacts the patients and the clients, okay? For now, we'll just kind of list it out. Case management, discharge planning, reintegration with pre-existing treatment team, which we did touch, family integration, how important that family piece is. Woo, okay, family piece. So imagine this. Somebody comes in, suicidal ideations, because they got into a fight because he got into a fight with his brother, and it turned into a fist fight, and they live under the same roof, right? He comes in, stabilizes his suicidal ideations. Imagine this, there's never any contact with the family to try to find some kind of resolution. He discharges right back into the system that destabilized him without any resolution. Seen it happen tons of times. It's like, this was the the precipitating event. And so looking at precipitating events, addressing precipitating events are it may not be the most critical piece of the stabilization trail while in the hospital. Sometimes it is, but once they are no longer in your care and they're swinging right back into that situation that didn't get any kind of resolution or get set on a path for resolution, detrimental miss. Okay. So who does desensitization really help? Right? I mean, we have to be able to separate from our emotions some, right, to be effective in our job. And we don't want to be completely attached emotionally, because then we may not be able to function, right? But when we're, but let's be honest, desensitization, it helps us as the providers, right? The providing teams. It helps us to be able to keep doing our job. And there's that healthy space with it, right? You know, it's like when I think about this kind of falls into it. And also my mantra of I want to always be emotional about my work without being too emotional about my work. I feel like it falls into this one, it leans into this concept in therapy. I think, hey, if I could only pick like one or two things that I could use and I could put in my bag of therapy tricks, if I could only pick a couple, one of them would be the concept of all or nothing. So important. There aren't too many things in this world that are okay as an all or nothing. Most of the time, it's got to be somewhere in here, right? And so when I think about be emotional about my work without being too emotional about my work, I feel like it leans into that, right? It's that space in between. If I was all emotional, I was no emotional, I don't know that I could be truly effective. Same thing with desensitization. The all and the nothing, if it falls into an all or nothing, again, I don't think a really healthy space. So desensitization, it helps us, but there is a healthy way to access and an unhealthy way to access. And when we go into that unhealthy desensitization, guess who truly who pays the price for that? The people we're trying to help, right? The clients and the patients. How do missteps become depleted quality of care? So here, we're going to look at a few different types of cases, okay? The first one, exploring care for the patient with chronic mental illness. We're going to take severe mental illness. Let's take, we'll call him, we're going to borrow my husband's name, okay? Because then that's kind of safe. Danny, we're going to call him Danny. So Danny has severe mental illness. He comes in for care. Coming in the front door, there's a couple of spaces. I'm going to jump to the tail end first. He's getting ready to discharge, right? He's, if we're saying severe mental illness, then we know that he likely stays chronically psychotic, right? It's just that right now, the state that he's in, his symptoms are amplified. He's out of range of his baseline. And so we get him to a somewhat stable, his baseline, and we prepare for him to discharge. Have we looked at his access to care when we transition him? Right? Have we looked, and I'm saying this not because I never see it. I'm saying this because I've seen it, and starting with my own teams when I've worked at facilities, there always have to be a lot of emphasis. And it's not because our teams don't care, is that sometimes they don't see it because we're moving so fast, right? So those of you in clinical leadership, these are areas that require so much oversight. You know, it's like, that's why it's good to stay attached with some of these cases so that we can guide and groom our teams to some of these things that they may not see when they're moving so fast. right? So getting ready to discharge okay, so is he on oral medications? Is he on injectable? Does he know where to go get his medications if he's taking oral medications? Does he know how to get to his doctor's appointment when it's time to go? Right? Who's watching out for him? It's another one. Is his judgment stable enough to know how to take his meds at home by himself? Right? So all of these things are so important in missing steps. And again, we go through the assessments, right? We hope that our assessments are informing some of these decisions. Going back to the front end, if somebody is coming in with severe mental illness, psychotic episode, and it's my case, I'm looking at it, and he's refusing medications. He's in his first 24 hours, and he's already refusing medications, right? Going into the second day, already refusing medications. Am I gonna wait till treatment team day on Thursday to talk to the doctor about him refusing his meds? No, not. I'm going to talk to the doctor and encourage that we go ahead and we attempt to petition for court order meds. Why? Why so soon? Why not give him a chance to to weave into the compliance? Because if his judgment is impaired and he's already refusing, he's not taking his medicine, and his medicine is what's supposed to help him get back to his baseline where his judgment is better. You're not going to get there if he's refusing his meds. He's going to keep refusing his meds. And even if he takes it once, he's probably going to refuse again a couple of days later. So don't waste time. If someone with symptoms like psychosis, chronic psychosis is refusing meds, jump on it. Go ahead and talk to the doctor and see if that's the right course for this patient, right? To petition for those court order meds. Why so important? Well, because if you delay, then now you're looking at, I mean, we don't want Daniel to be in the hospital for 20, 25, 30 days, right? Not if we can help it, right? But that's what it turns into if we delay. Right? By the time we decide, okay, let's go ahead. And then by the time we get the papers in, we get the hearing and we keep moving and they get the first injection and then we have to wait and get the next injection. We are well into the 20 days, right? And there's another impact. Wow. And it's like, well, it's okay. Let him. I mean, he's safe here. He's getting good care. Yes, but at the same time, we're also using up his hospital days. Right? They don't have unlimited hospital days. A lot of times people in the category of SMI are on Medicare, right? And there are no unlimited hospital days. And so the longer that we have somebody inpatient, the more days that we're using up, and we want to preserve them for them, especially for this population that undoubtedly at some point or another is going to need another treatment state for stabilization. Let's go to looking at the client in addiction treatment with co-occurring mental health conditions. I feel like we've been talking about this one, right? So we won't dig too deep on this one. And some of the scenarios that we talked about were what are some of the symptoms we might see that are pretty common in the addiction treatment setting? Depression for sure, right? Anxiety for sure, PTSD for sure, bipolar for sure, mood instability for sure. All of these conditions coming into treatment. How many people that are in addiction are taking medications in a way that's going to support stability of their mental health condition? It's unlikely. It's more likely that their symptoms are going to be exacerbated or their mood is going to be out of whack, right? It's likely that they'll need a reset on medications, and it's extremely difficult for them to function in the intensity of the treatment that we want them to participate in when you have that part lingering there. I have seen some situations where in the addiction treatment setting, it might be, okay, so Monica's at day 20. She has 4 days left and she's going to transition now. But I wanted her to go to PHP, but I don't know that she's going to benefit because she really didn't benefit from the groups in residential. She seemed like maybe she was responding to internal stimuli, right? Something seems off. And well, how long has Monica been presenting that way? Oh, probably since the first 5 days or so, since the very beginning. Okay, so here's someone who fell through the cracks. And it wasn't until that moment where the transition was needing, it was impending transition, that now that consideration for appropriateness for the next level is really being taken seriously. But if it was caught up front, does it necessarily mean that Monica would have to go step up into inpatient? Sometimes, yeah, sometimes it means that, but it doesn't always. There are, depending on where the intensity is, there's a lot of stabilizing that can be done at the residential treatment level, right? So if she had been caught at that point and interventions put into play at that time, she would have benefited from this 20 days in residential, as opposed to being at 20 days and saying, I don't think she got anything from it because she's symptomatic. So those are not rarities. Okay, unfortunately, they're not rarities. Refusing medications, she's not taking her meds and it's causing her not to be able to focus. Okay, I think we should discharge her because she's not benefiting. No, let's weave it into the treatment plan. Let's make that her next goal, right? It's like, let's work through what's holding her back in her med compliance. What is holding her back? Let's weave that in and work through that. Look at it as a barrier, right? It's the next barrier to break down in her road to recovery. And then our last example, the client with the recognized and the unrecognized trauma. So both sides, the unrecognized, I think that happens when we're just moving so fast, not doing the readbacks on the assessments, not seeing beyond the obvious, just surface level symptoms. And it's so easy, again, like we've said many times throughout this discussion, it's so easy to associate disconnects from our clients in residential settings, and to confuse it with not being ready to get sober, right? Not serious about this. It's so easy to confuse it with that. So sometimes the unrecognized is just that we haven't done that deep dive. And on the recognized side, so this one is a tough one for me, because even in the acute setting, every level of care we see this, right? But in the acute setting, when someone presents with acute symptoms and they want to work on their trauma, a lot of times what they'll hear is, well, you're only here for a week, so we really can't work on that. I think that's the wrong answer, okay? I don't think that we open up their trauma. Again, I'm going to say it again. I don't think that we open up their trauma. But I think that there are things that we can do to help them, such as prep work, right? Educating them, just getting a baseline of their symptoms and their symptom intensity, getting some education in there and starting to connect them with some of the treatments that are available that will help them as they're moving through the continuum of care. Beginning some internal resourcing, skill building, right? Coping skills, so that they can begin to use some of those, 1 or 2 or 3, right? Towards some of the symptoms that they're experiencing now. There's prep work that can be done, even in an acute setting. It might be a little bit challenged in a week and a half, a week, right? But at a minimum, if you assess the trauma, identify it, and put it on the discharge recommendations, connecting them with the right provider that could continue to do that work for them in the next level of care. That is addressing trauma at that point, with the full stability that they can, right? So what happens is, I'm sorry, we can't touch on your trauma because you're not here long enough. Then they go to residential treatment and they're there for 20, typically that's the plan, right? 20, 30 days. And they're hearing the same thing. I'm sorry, you're not here long enough. We can't open up your trauma. That would be irresponsible. So then here we are again, delaying and delaying. And that has the potential to have so much impact, compound the symptoms, compound the trauma, right? When we know, just from what we talked about acute, there are things that we could do in 20, 30 days that are very helpful. Most people don't just dive into trauma. Most people prepare for it, right? We have prep work. And so it's some of these levels of care. We have that. So when we're recognizing it, but we're not recognizing it within the treatment plan, big miss. Okay. Okay, guys. So let's take a break. Let's take 10 minutes. Okay, so it's 11:07. Let's swing back in at 11:17. Okay. Okay, so we are on our last stretch here, guys. In this last section, where we're working towards synergy, right? We're pulling together what we've been talking about to get to that space where we're doing our part to create those seamless transitions wherever possible. An example that I think about that had come across my mind is like when you're running, well, I'm not going to say the 400 meter because we have 5 levels of care, right? So we'll say the 500 meter. And it's like, we don't want in a 500 meter relay, you pass the baton, 100 meters, pass the baton, 100 meters, pass the baton, 100 meters pass. And they're all working together as a team, to get through this relay, right? Each team in a relay isn't running 500 meters on their own, right? That's not the goal in that. And I think of that example when I'm thinking about how ideally how we want to be able to operate in that handoff mentality, right? So when we were looking at the last slides, we were touching on trauma to some degree, right? And so here, when we're plugging it in here, is because we're looking at it through the things we should do, reiterating the things that we could do, right? I don't want to use the word should because there's always those outliers, right? Things we should, things we could do. And recognizing that trauma it's very real, and people are waiting for us to help address it. So here, why does trauma matter? 75% of clients with substance use disorder have trauma histories, right? And as we've said earlier, oftentimes the addiction is actually a symptom of the trauma, right? That's when we think about the way that trauma operates, and we're looking at, well, in order to avoid, people will often access, they have like this very unhealthy coping box that they use to help them suppress and continue to avoid, right? And then coming here, risks, unprocessed trauma triggers, unprocessed trauma triggers relapse. Avoidance reinforces trauma responses. You know, one of the things that we do know about trauma is that avoiding the trauma and suppressing it and avoiding it actually keeps it in real form, right? That's the hypervigilance, those flashbacks that feel like you're still there because it hasn't been able to go through that processing to go through the desensitization processing, right? It's just stuck here. And so avoiding perpetuates more trauma. So then if we say it that way, avoidance perpetuates the trauma. And we're in our settings avoiding. Are we helping the trauma? Are we hurting the trauma? Potentially hurting the trauma more, right? Recognizing early warnings, early warning signs, right? So when we see people that are isolating, they're trying to avoid being a part of things, they're hypervigilance, flinching, they're numbing emotionally, their stress reactions seem like they're disproportionate with the occurrence. Those could be some early warning signs. Go back and look at the assessments and see what's in there. And if nothing's there, you could always talk to that patient or that client also to dig into where these symptoms are coming from. Clients will often tell you about their trauma. They'll often disclose that they have trauma. They won't not necessarily elaborate, but they'll give you a clue that it exists, right? But sometimes they won't. Sometimes they will just drop little hints like, I've been through a lot, or I don't want to talk about my past, right? And those are little subtle hints that something could be going on. And then again, same emphasis, avoidance prolongs trauma. Here, we're looking at some trauma-informed steps, right? So these are some of the things that we can do, is like we talked about that prep work. This just shows another way, it's illustrating it in a different way, right? So like if we know we can't really do that trauma work, we're opening up the trauma and working with it and reprocessing it. These are some steps that we can take. We can focus on education, just informing them about some types of therapy that are out there that could be very helpful, like cognitive processing therapy or EMDR or brain spotting, helping them understand what stuck points are or what memory processing might look like in the future. Just giving them some insights can set them on course for some hopefulness about what they will work on in the future. Could it have the adverse effect? It could, right? It could scare them. But I think as clinicians, we assess for their readiness to go into some of that. And so if we're touching on education, we do little sprinkles to test the water, right? And we give them a little more as they're responding okay to it. Stabilize, just making sure that there's suicidality, that there's no SI, right? They're stable in that sense. And that they're demonstrating the ability for immediate coping, right? And then validate and prepare, acknowledge the impact of the trauma, even just acknowledging it and saying, it makes sense that you feel like that. It sounds like you've had a rough time, and I look forward to the day when you're going to start working on this, right? Begin working on the internal resourcing skills. And this is one of them that I particularly really like to target in private practice is like, and because what's one of the biggest symptoms in PTSD and trauma? Anxiety, right? And so working on an anxiety skill, I've come up with this little framework that I like using where some of our preparatory work will be learning the personality of their anxiety, you know, and we build out the scale and it's numbered and it's also categorized. And we don't, it's 1 to 10. I usually leave 0 off. I just say 0 doesn't exist, cross it out. We're not going to go with 0 at any point, right? Because somebody that has anxiety disorder, that's a hard strive for a 0. So you've got your 1 through 10 separated also by categories. Your 1 through 4 is your mild, your 5 through 7 is moderate, and then your 8 through 10 is severe. And then beyond that, and then just with that itself is working on helping them identify where they are at any given time when their anxiety is elevated and they feel the discomfort, to start learning how to categorize or to quantify, right, their distress level. And why? Because beyond that, some of the other work that we do on their anxiety skill and learning the personality is, okay, so in these categories, right, what are the symptoms that you feel in these categories? Because symptoms don't necessarily feel the same in each. It doesn't necessarily feel the same at severe as it does at mild, right? And vice versa on all of them. So what are the symptoms like in this category? What are the symptoms like here? What are the symptoms like here? And then there's also, so what types of things might trigger you to, you know, to uptick from this to this category, from this to this category, right? And individualizing it per category. And then the next one is, okay, let's start working on what coping skills, what soothing mechanisms are effective for each category. And there's another important part of this that I like to emphasize is when I'm working with someone on this scale, one of the points of emphasis is I encourage them that when they recognize, they quantify, or they categorize where they're at, I say, don't work on regulating. I know that sounds weird, right? I'm like, if you are at an 8 and you start focusing on wanting to be at a 4, you're not going to get there fast enough. You're not going to get there fast enough. And you know what's going to happen? You're going to get more anxious. Instead, focus on self-soothing, just being able to tolerate where you're at. Focus on that. And that's what the soothing mechanisms are. Just focus with the number you're at. Don't try to change it. The secondary gain is that then you naturally regulate, right? That's the hope. That's the hope. But that's one of the strategies on that. And then under refer, big step, secure a trauma trained therapist early on, provide a strong clinical handoff to the receiving provider. You know, we talked about this. That's a big miss sometimes, is giving those specific recommendations to hand off. And then the person that receives it just starts all over. They don't even know what work they did, right? Not a good system. On the other one, on securing a trauma-trained therapist, you gotta start early, because if you wait the last week of discharge, good luck finding a trauma-trained therapist, EMDR therapist, brain spotting, you name it. Good luck finding someone that's going to be able to get your person in within the first 2 weeks, 7 days, 2 weeks. Good luck. 30 days, good luck. So the earliest you identify that this will be a need, start working on that appointment. Okay. And here's just trauma-informed approach. It basically talks about what we just looked at, educating, stabilizing, using different breathing techniques, sensory checks, and helping to teach them that as the prep work. Why does this work? Because it validates their struggles. It avoids re-traumatization. It helps to build trust, and it empowers them with tools. And we know that with trauma, there's a lot of disempowerment and a lot of feelings of victimization that are embedded in there. So empowering them with tools at this phase could be very helpful. And this is just one of those phrases that one of my other little phrases, right? There, once upon a time when I was working in that one case management job, case managing people through vocational programs and college and reintegrating offenders and such, a coworker of mine asked me, how do you motivate people? And in a roundabout way, I kind of landed on this phrase. You know, I said, I feel like when we see that someone else can do it and it becomes tangible, then we become inspired to do it too. Right. And then that's kind of where this comes from. And I believe in this. I believe in that. When someone connects with something that touches their soul, or something that wakes up their spirit, that it can be very motivating. And when they're motivated, that's when you're more likely to see some actionable change from them. And here, we'll take just a little bit of time on this one because we've done some work on here. What I want to do is I want to look at it from the flip side. We've been looking at these things from the things that we're missing. I want to look at it from, hey, let's look at it from a seamless system and with synergy in mind. What does this look like? Well, the way this looks like, if my team and they're taking care of Daniel, the way it looks like is my team is coming in. They're taking a look at Daniel's assessments in the first 48 hours, taking a look at how Daniel is doing with his medications, right? And they're immediately having conversations with the treatment team upon any refusals, so that they can determine if the right course is to go ahead and start petitioning for court order medications, right? At the tail end, my team is working on connecting Daniel with intensive mental health case management services, right? With local mental health authorities, organizing for someone and setting it up where someone will meet them at the day of discharge, take them back to the crisis center in the community to get him signed up, make sure he gets his outpatient meds, make sure they've got that appointment with that follow-up provider, and doing those in-home visits to monitor med compliance, and to make sure that he's continuing to get his injectables if that's the treatment course that he's on. So that's what that would look like, right, from the acute inpatient setting for Daniel. Looking at the client and addiction treatment with co-occurring mental health conditions. In this case, my team would get the case assignment, go review, do the read back on the assessments, right? Take a look at barriers and start and make family calls immediately to start that connection with them, right? Look at barriers and start working on the breakdown of barriers before they become a problem. right? Look at the co-occurring conditions, mental health conditions, and looking at the medications, assessing his symptoms and asking, how are you feeling about your anxiety? How is this going? That way, we can use that information to inform the rest of the treatment team and the medical provider, right? So there's that front end. But also in weekly therapy sessions, my team would be monitoring his integration into the treatment elements of care. They might need to specifically plan around that, right? So that he can, it might look like, okay, Daniel, I know that the big group is hard for you. I know your anxiety is still not at your baseline yet. We're going to work on some coping skills that you can start building up so that you can rely on too, and not just rely on medication, right? So build up your internal coping skills. And what we're going to do is for the next 3 days, we're going to target, instead of 60 minutes in that group, let's do 15 or 20 minutes. And these are the strategies you're going to use. And then we're building up, right? We're building up from there. Going to client with recognized and unrecognized trauma. Feel like we've done this one where we said what we would do, but let's suck. I'm going to pay attention to what the assessments say about trauma. I'm going to pay attention when I'm asking about the trauma. And then if I feel like I need to do a deeper dive, I'm going to do a little bit of that without opening up any of the trauma. I'm going to identify if there has already been some structured trauma and to what degree the trauma has been attended to. If there has been none, I'm going to go ahead and start educating my client and say, and assess whether the current level of care would be appropriate to begin that. And if yes, at what degree, right? It may be prep work, and I'll talk with my client about his readiness for that. You feel like you'd be ready for some education. You feel like you'd be ready for some coping skills, all in preparation for some of the future work, right? And then when I'm transitioning, when we are transitioning, this client, we would provide a strong handoff to that trauma trained therapist that we've already set him up with a couple of weeks back because we knew we wouldn't be able to get him on there. So what happened to Jane Doe? Well, I wish that I could tell you that she is reestablished, or she has established, because I don't know that it ever really happened. I wish that I could tell you that she's established trust with the mental health system, with the continuum of care that's supposed to be there to help her. She's making her way, but she's not the same person, right? This independent, vibrant woman that was so career oriented and just strong to the bone. She hasn't been able to work in a couple of years, right? Her trauma symptoms are just too strong. She's disconnected from all her family. She's coping with mechanisms that sometimes we see in addiction, like aggression, right? Like some of that is coming out in her efforts to try to suppress and not confront the trauma. And part of not wanting to confront the trauma is because she doesn't trust the system, right? And so hopefully Jane's story doesn't end there. I'm hopeful that it will continue to move, right? But the actions that we take every day and the work that we're doing, they can help or they can hinder that process for lots of different people like Jane. But at the same time, we do so much amazing work every day, right? That I also want to say magic wands don't work. And I know that that doesn't really look like a magic wand. I was thinking it looks more like a cigarette, but it's supposed to be a magic wand. And magic wands don't always work. I mean, we don't come with magic fairy dust, right? We can't have control of everything. There's some things that are controllable within our abilities, and there's just some things that are out of our control. When I think about this controllable and out of control, especially being in the addiction world, my mind goes to it. So remember that if I could only have a couple of things in my little therapy bag, and the other one was all or nothing. think the other one that I would pick, I'm gonna pick this because I think like these are some of the most clever words that were ever strung together. I feel like just in these 3 lines, they're so significant. You could get so much from it. So I take those 3 words and I put those in my bag. And it's the first 3 lines of the Serenity Prayer, right? Serenity to accept the things I can't change, the uncontrollables, the courage to change the things that I can, the controllables, and the wisdom to know the difference, right? That insight, that awareness, right? So that definitely goes in my bag. And then again, like I said, with the good work that we do, we sometimes make our best efforts. This is a little poem that I like sharing with patients at times. When I was working at facility level, it was like a poem that I like putting in their little recovery kit, their folder that they get, their welcome kit, or sometimes it would be something that would be up in their room. And I feel like it emulated the care and the compassion, but it also said, hey, you have to walk through this too, and we're not going to be a part of a codependent or an enabling relationship, right? So to listen, we are here to listen, not to work miracles, to help you discover what you're feeling, not to make your feelings go away, to help you identify options, not to decide for you what you should do, to discuss steps with you, not to take the steps for you, to help you discover your own strength, not to rescue you and leave you still vulnerable, to help you learn to choose, not to keep you from making difficult choices. We are here to provide support for change. And here we swing back to the phrase, which I encourage for you as well, right? Be emotional about your work without being too emotional about your work, finding that happy space between the all and the nothing, right? And as we get close to concluding this, I want to challenge you to, to leave this training and to do some self-reflection as well as and reconnect with the story that led you to this field and the helping profession and those elements that contributed to the house that built you as well. And so I encourage you to do that reflection for yourself. I kind of wish I could hear some of your stories. And I'll leave you with this. Being a part of someone else's healing process or search for meaning is an extraordinary experience and certainly a privilege. I thank you guys so much for joining me today. I loved sharing this with you, and I hope that you got something meaningful from it. At this time, I'm going to swing you over to Zach, and he has a few closing thoughts for us.
Thank you, Monica. Appreciate the content, and you're not keeping up with the chat, but it is exploding with lots of gratitude. Throughout the session, there were many people who were responding to your stories, who had many shared experiences, especially relevant folks who have been working in acute settings themselves, whether currently or maybe that's where they started their career, and could certainly share your sentiment about all of the skills that they gained in those settings. And that was kind of where I wanted to start with some kind of Q&A and questions. And for those of you who are pounding away at the chat, you can also use the Q&A to put some questions our way as well. Those will be a little bit easier for us to see than trying to see them in the chat. First question, you did talk about your experience and certainly the pace in these more acute settings. And lots of people were responding to that about the fatigue that they can face in those settings. Any personal tips on self-care and wellness so that people can have longevity in their careers working in the difficult spaces that we all work?
Take your breaks. Take your lunch break, take your 15-minute breaks. That's on the small scale, right? Some days are harder than other days, right? Lean on your team and let your team know when you need their support. In the set, it's like that, having a battle buddy team in my experience, it's what got us through. Just having that battle buddy team. It was like we could get through anything, right? But when we were feeling like we were doing it alone, it was much, much harder, right?
Thank you. As you walked us through the different levels of care from most acute to less acute, as we went from that journey with you from the inpatient psych to outpatient, um, had a question come up about documentation and how goals in particular will transform as people move through those settings. Can and recognizing that not everybody on this call has experience working in all these levels of care, but can you maybe shed a light on how that documentation would differ from the acute care world, in inpatient psych? What kind of goals are we documenting towards that are certainly going to be different for somebody, let's say in that outpatient? Um, and then how do we kind of course, carry with the through line through that continuum of care, and whether that's with the same provider or more likely using different providers, stepping people down through that process.
Well, at the highest level of care, it's quite typical for their primary goals to be around stabilization of the crisis symptoms, right? And there are typically going to be things that will be recommended to participate in and to help facilitate that. Some of the things would be some of the standard things, right? Like um being compliant with medications, right, while they're
Mm,
stabilizing, attending particular groups that have been deemed to help with some of the sense of hopelessness or helplessness, right? Targeting some of those emotions to get that fellowship and that support. Sometimes that can be a magic wand sometimes. Um,
mhm,
documenting and I feel like at every level of care, there's identifying what their symptom intensity is. That's kind of the easy way, right? Is what's your symptom intensity? Where do we want you to be? Right. So it's like, okay, so that's a goal. We're trying to achieve this, this digression. We're trying to this reduction in intensity of particular symptom. And then as a therapist, we may give some suggestions that will help to do that. And it's good to do it from multidisciplinary, naturally, right? The medical provider is going to have a piece of that, right? In his medication management, and nursing may have it in helping to administer and helping to provide medication education. The therapy team, we kind of gave an example when we said, ooh, when we don't touch on the precipitating event, that would go in there, right? So precipitating events that are exacerbating symptoms should go in the treatment plan as the targets, some of the targets. And we got to be careful, because if we're so used to as clinicians to document to the positive because we want to
mm,
show their growth and their progress, but sometimes we hurt them by doing that because we need them at that level of care. So we've got to document to the negative. I'm not talking about creative writing. Okay. I'm talking about their actual symptoms. And that's where, when we were discussing how the IDT is important, because different people see different things, right? And pulling that into the documentation is critical for being able to keep people at the level of care they should be at. If we don't have the documentation in there and we're faxing in for concurrent reviews, we're not going to get the time, right?
yeah, I think that's an important concept to hit on, and I find that we don't do a great job in our shared respective field of teaching people how to document very well, and finding that there's realities with documentation, UR and processes where people are not necessarily coming out of school thinking about facing insurance denials and advocating for their client, where they're going to have to focus in on that justification. Too often, I think, to your point, we're focusing in on the growth, the positive, that's what we're there for. But it is that difficult give and take, finding that balance. We're seeing some
Yes.
people in the chat agreeing with that. We had another question come in from must be someone who certainly works in an outpatient, likely private practice, is what I'm imagining, and they wanted some feedback on how they might go about approaching a client when they feel that there are circumstances that are going to necessitate moving them to a higher level of care, and especially if that's going to be in a much more acute setting. So, what are some tips of the trade there, things to look out for, and then how you make sure that they get there safely, and then reintegrate them, hopefully when they've been stabilized and come back to their services.
Well, that question really depends on what the symptoms are that are presenting that may necessitate the step up, right?
Fair point.
Right. So if and it depends on the person, because some individuals are, they're okay about getting the help, and you just need to tell them what you're concerned about. And they'll, if you say, I'm really worried about the suicidal thoughts that you're having. I mean, I understand that sometimes you have some hopelessness and helplessness, but right now I feel like it's escalating and I'm not going to be able to come home with you. And I need someone to assess you and make sure that this is still the right level of care for you. It's like, oh, I know I live in a small town. I would say, I'll follow you there and I'll walk you in and I'll hand you off to them and I'll wait till we find out what's happened. I'm not suggesting that you do that. I live in a small town. Right? But sometimes I just look for that thing, and I'm hoping that I have rapport with my person already, right? So I look for that thing that will bring them comfort, and I try to pull that thing in. And I wish that there was a black and white response for that, but there's so many nuances that differ the responses across symptoms and patients and situations.
Absolutely. One audience member spoke about generational trauma. So you in the latter part of your presentation, you focused a lot on trauma and exploring that, and some of the ways to work specifically with a client. As I'm sure you see and can echo what this person is saying. You're working with a client, but they're parent, their grandparent, who's part of the constellation of the family system, also has had trauma, and it's informing all of this in this kind of perfect storm of presentation that can create challenges, barriers to the immediate treatment of the identified client. Can you maybe put it into context for us, some of the challenges with generational trauma, and maybe some of the experiences you've had about working with that identified client?
Sure, I'm going to take it from, I'll take it from an outpatient standpoint, outpatient traditional therapy, right? I'm going to assume that because my person is in therapy with me, that they want to get better and they're seeing that something's not right. They want something to change. So I'm going to feed off of that initially, right? And my approach in therapy, I categorize it in 3 pieces, and I feel like it would apply, right? So it's like, 1, identifying it. But in phase 1 for me in therapy is education and knowledge. Feed education and knowledge, right? The second phase is that I hope happens, is that the awareness and the insight then develops, right? That the education and that awareness, and then the awareness and the awareness and the insight. And then my hope is, once you get this and you get this, that then you start to get some actionable change. But this middle one is so critical. But then this one doesn't really happen without this one. Now you can fake it till you make it with actions, right? But that's not sustainable. For sustainable change, this and this has to happen. So then I would use that same framework as I'm trying to educate, and I would start there and helping them just to see and educate from a more general standpoint, moving it to self-awareness and insight to prepare for some of the breaking of those cycles, right? And there's so much embedded there, because sometimes it doesn't mean that they separate from their families. They still are embedded in each other's family, and they have to learn how to live a different way that's different from the way their family is living, right?
Yeah.
All that goes through this process too, right?
You spoke briefly about in-home services. And I think one of the areas you talked about was the value that we can have of being in home, and especially for checking in on medication compliance, which might be easier to do in the home than relying on people to bring that into a clinic setting and things like that. High level, can you speak about some pro cons about in-home services for those who maybe not experienced in that avenue of providing care?
Well, the pros are easy to speak to for if we're looking at in-home care for particularly for SMI, right? Severe mental illness. The pros, I think, are the ones that are the easiest to see, is that you can they're going to be able there's it's more sustainable stability, right? When I think about the cons, I feel like it's more centered on barriers,
Mm.
right? So some of the barriers that the providers encounter when they're trying to provide these in-home services is that often the client won't be home, can't find them, and so forth.
Mm.
So then that creates that disconnect, right? But it's hard for me to think of a con when I'm thinking of that population when they need that. I guess we need to be careful too that how much that we don't just cluster everybody under the same category. That as we're assessing what someone needs, that we're also keeping in mind how much judgment they have, how much independence they can have, right? And we don't over help where they might be able to help themselves. But that's all part of the assessment process, right? And the recommendations. It's like he can do this, he can do that and that, but he needs help with this. And that we promote, we advocate for independence where he can have it or she can have it, but advocate
Mhm.
for help where he needs it to maintain the independence.
Okay, very good. All right. Looks like we've addressed many of the questions. I'm going to look back at just a couple of these. If I'm failing to cover your particular question, it might be because I don't exactly know what it means from the context of the question, so hard for me to rephrase them. Giving another moment for any feedback, not seeing much, but we are seeing so many thank yous as people are popping off. We look like our attendance is starting to dwindle in our last couple minutes. So I'm going to take the opportunity to thank you, Monica, for the informative session and for playing along with us for the 3 hours, all of you at home, and hope that you found value in today's session. As I mentioned earlier, we will continue to plan out an additional session for 2025, probably to happen in December. We have been putting the evaluation link in the chat. We're going to do it a few more times so that you can try to grab that link if you want to before it flies away in the chat. If you don't get it, don't fret. You will get an email later this afternoon that will have that. As well as in that email, you'll have a copy of the slides. You'll have a link to a video link for this training, so you can go back and listen again if you so choose. Reminder that completing that eval, very, very important. You've got to do it in the next 30 days. I recommend you do it as soon as possible. And you get that in. If you don't complete it in the next 30 days, you will be ineligible for the continuing education credit. Someone is asking, well, if you for the email chain for the next one. So by registering for this one, we now have your email address, so you will be part of our distribution list for future events. If you're not getting those, I still recommend you check in with us on social media. If you follow us, The information for our social media is on your screen right now. You will be also getting information through there. You can also check out our events page on our website. We do post those about 6 to 8 weeks before the actual session. So we will be updating that within the next month or so. All right. Thank you very much again, Monica. This will conclude our session for today, everyone. Thank you again for attending. We'll see you on the next one. Have a good, wonderful rest of your day and weekend. Take care.